babies who are born premature already respond to sweetness with a smile. It releases endorphins, it makes them feel good, and so we don't need to learn to like sweetness. Fats are heavily rewarding. The brain responds with pleasure to whatever it finds helpful, and they want to repeat it. So when you live in an environment full of sweets and fats and stuff, your biology rules will tell you to eat that. But we need to work on our learning, and we can also change what we like to eat, but we need to work and associate the flavor now with the post-ingestive consequences of the calories that you get.
Welcome to Longevity by Design, a podcast designed to give individuals access to the leading scientific information in the field of longevity. The ability to add years to your life and life to your years needs no opinion. Join us as we ask science to take the wheel. In each episode, Dr. Gil Blander joins a co-host and an industry expert in the field of longevity, shining a light and getting the answers to the key question: how can we live a longer, healthier life?
Hello, I'm Dr. Gil Blander. Welcome to Longevity by Design, How to Live a Longer, Healthier Life. We are produced by InstaTracker, your science-based guide to optimize your body from the inside out. Our guest today is Dr. Yanina Pepino, who will discuss taste, smell, preferences in humans. Dr. Pepino is Associate Professor of Ingestive Behavior at the Department of Food Science and Human Nutrition at the University of Illinois. She received her PhD in chemistry from the Faculty of Chemical Science, National University of Córdoba, Argentina. After completing her graduate degree, she was a postdoctoral fellow at Maternal Center in Philadelphia. Before joining the University of Illinois, she was research assistant professor at the Center of Human Nutrition, Washington University School of Medicine. In recent years, her research has focused on individual differences in taste perception, food preferences, and ingestive behavior. Among the individual differences, she has a particular interest in studying those related to obesity and addiction. Dr. Pepino's current research interests include understanding the effect of bariatric surgery-induced weight loss on flavor perception and eating and drinking behavior, human fat sensory perception, and the effect of non-caloric sweeteners on the taste preference and the glucose homeostasis and taste and smell function in clinical population. Welcome so much, and I'm really excited to discuss this subject with you. It's really interesting, the research that you are doing, and maybe we'll start by a bit of a background on you, and specifically, why have you decided to become a scientist?
Well, first of all, thank you for this invitation, Gil. I'm excited to be here and to find out that other people find what we do interesting. In regards of what really pushed me to be a scientist, I think that it's a little bit of like almost everything is a little bit of nature and nurture. And nature, I would say that I was born with a big curiosity. I think I never grow up this phase of curiosity that all kids are born with. And that I've been hardwired in a way with my personal trait is that I found a lot of pleasure in learning. And so it really is very motivating, and I want to keep on learning. And I think those are traits that I will probably agree a lot of people who are scientists would have. And that when you put it together with nurture, I had really the big luck to be mentored by amazing scientists and people who not only were very good and having this enthusiastic and passion, who was very contagious for science, but also that they showed me that a career in science was a feasible career pathway for women. And so I think that I really am very grateful to having had these amazing mentors who inside me to and let me discover the wonderful life to be a scientist, which I think is more than a profession, it's also like a hobby.
Yeah, no, that's great. And what drove you to decide to research taste, smell, preferences in human?
So that was kind of the first bite into science that I got when I was a graduate student. I was studying chemistry, pharmacy, and I was contacted by people working in a neuroscience institute. They were psychologists. My mentor was a doctor in psychology. And he was interested in understanding how early in life, how being exposed, for example, to the flavor of alcohol in the womb when a woman drinks during pregnancy or breastfeeding, how a fetus or early on in life, you could learn a preference just by being exposed to this. And I'm coming from chemistry. I was given the task to find how much alcohol there actually was getting into the amniotic fluid and mother's milk, breast milk, when dam, we're working with a model with rats, when they would drink a moderate amount of alcohol. And since then, it really opened an amazing world for me of understanding how, since very early on, since you are in the womb, you start learning about the flavors of your food. And not just food, you could learn about the flavors of, a preference for alcohol or even smoking by early exposure in the womb and through breast milk.
Okay. So what I'm hearing from you is a woman that is pregnant and drink a lot of alcohol, that might make a kid in future to be also attracted to alcohol.
That's correct. So first of all, a woman should never drink during pregnancy because there is no safe amount of alcohol for physiological reasons. There is a fetal alcohol syndrome. There is a lot of problems associated with exposing a fetus to alcohol in the womb.
Mm-hmm.
But this was a much subtle concentration or dose of alcohol that we were interested in to study, even if the flavor of alcohol, so just a little bit, just maybe having one drink of alcohol during pregnancy, how much of that alcohol will get and taint the amniotic fluid and give that flavor that could attract later.
Wow.
And in animal models, we found that when they were exposed early on, then they will consume more alcohol later in adolescence.
Wow.
And even if they were exposed during breastfeeding, we found something similar.
And do we have evidence in human that a woman that I assume that some of them they don't stand the temptation and drink a bit? Do we see that there is a correlation with how they?
It is more difficult to prove. We know that it's a model that has worked in evolution to teach the like mammals, what they should be eating after they're born. And we think that it applies to alcohol as well, because there is some data that kids who were exposed in utero, even if they don't have the whole full-blown for fetal alcohol syndrome, that there is a higher prevalence on also attraction to alcohol. So it seems feasible that what we learn in rodents, it translates into humans. It's more difficult to document alcohol exposure to small amount of alcohol and that, but there is a lot of reasons to believe that what we know in humans, for example, it works for other things. It works if babies are exposed to carrots, to different smells and things, garlic in the diet, that then they respond more favorable and respond with familiarity and preference to those things in early on. So
very interesting. So for women that are pregnant, whatever you eat during the pregnancy might influence significantly the preferences of your kids in future.
Yes, which is amazing. And I think something we really need to capitalize on, helping pregnant women breastfeed and to eat healthy. So we are starting the new generation to like things that are healthy.
Move from McDonald's to Whole Food.
Totally. To food that look like, not edibles, but foods that are
exactly.
nutrients.
That's good to know. And I didn't know that. That's amazing. A very good lesson for our audience. So what are the individual differences in human taste perception and preferences? And why do we have those differences?
This is interesting. You go back again to nature and nurture. So some of the things that are different between people are from genetics, that nature. Like, there are many polymorphisms, variations in receptors that are coding our sensors for detecting taste, detecting smell, and therefore flavor. And so, for example, the most commonly known is a difference in one of the 25 bitter receptors. There is a big family of bitter receptors, but there is one in particular that there is a big polymorphism, like, around 30% of people in the planet overall are, for example, non-taster to some very specific bitters, whereas other 30% are more like super tasters, and there is like the rest, which kind of like a moderate tasting.
Yeah.
And so, of course, depending how sensitive you will be to that bitter, like if you're non-taster at all, you will, for example, find that more acceptable to eat broccoli, spinach, cabbage, and some things that have this bitter. Whereas if you're super sensitive to that bitter, it would be more offensive for you as a kid to learn to like it. And so the genetics will have a big impact on how at least you respond initially to foods. But on the other hand, the good news is that learning has a huge effect on nurture and early exposure, even exposure in utero, we just talked. Since then, every episode of of eating is a learning episode. So we can teach ourselves to learn a preference for foods that are healthy.
Yeah.
And so it's more that we eat what we like than we like what we eat than we eat what we like. We
Yeah.
do both, but you can train yourself to really like the food that you are exposed.
Yeah. Yeah, and I have a good example. I really didn't like avocado, but I realized that avocado is good for me, for my cholesterol and other. So I force myself to eat avocado, and I like avocado. So it's a great example of when you know and understand that there is a value of the food, suddenly you change your perception, and suddenly the taste become nice for you, which is
And
interesting.
so it takes a little bit of work. The
Yeah.
thing we have is that currently we live in an environment where, so some of the things are ingrained. Some things we are inborn. It's like in our hardwire. Attraction to sweetness, attraction to fats, in particular attraction to sweetness
Yeah.
is, for example, in our roots, in our brain. You don't need to learn an attraction to sweetness. Babies who are born premature already respond to sweetness with a smile.
Yeah.
It releases endorphins. It makes them feel good. And so we don't need to learn to like sweetness. Fats are heavily rewarding. And so, dense condensed calories. So the brain responds with pleasure to whatever it finds helpful.
Yeah.
And they wanted to repeat it. So when you live in an environment full of sweets and fats and stuff, your biology rules will tell you to eat that. But we need to work on our learning, and we can also change what we like to eat by we need to work and associate the flavor now with the post-ingestive consequences of the calories that you get. So your avocado, now you're associating your brain that flavor with how you feel, because you have good nutrients, you have good calories, and you feel good after you eat. And so next time you'll be more likely to eat it. And after some time, you even have a preference for it.
Yeah. No, that's a great point. And I think that another take-off message, if I understood you correctly, is as a parents, we have a lot of power and responsibility to train our kids, because if you will go every day to McDonald's, they will continue to go to McDonald's. But if every day you will eat a home cooked meal and it will be healthy, more chance that the kids will continue to do that. That's correct?
Correct. And you're right on target on, this is very strong evidence now. When I had the luck when I was doing my postdoc at Monell Center, a center dedicated to flavor, taste, and smell. And Julie Menela had these beautiful design studies where they will take babies when they're starting to eat their solid food.
Yeah.
And what you just say, whatever you're exposed, they learn to like even that even more. So if you give them, for example, exposure to carrot puree or bananas puree, they will just only learn to like it more and more and eat more. But if you give them a variety of fruits, then they will even like fruits that they didn't taste, but they learn about having exposure to varieties. So if you want them to eat green beans, you don't give them just bananas and carrots. You need to give them spinach. And you can give them green beans a lot, and they will learn to eat green beans. But the best you can do, there is data, you need at least like 10 exposures to different vegetables and things, and increase the acceptance and liking of variety of vegetables and fruits. So the first 2 years are key in shaping these preferences. It doesn't mean that if you were not exposed the first 2 years, you will not learn. We could always learn, but there is a big impronta and that learning those in the first 2 years.
Yeah.
And so we should put a lot of campaign on that, healthy eating early on. But definitely, even if you pass that window of time, it's about repeating and eating a healthy food that will make you like and prefer those food more.
Yeah, I assume that it's like language. It will be much easier for me to learn Spanish when I'm 2 years old than now. I can learn it, but it will be hard. So it makes a lot of sense.
That's right.
So is there a correlation between a taste perception or smell perception and a lack of a specific macro or micronutrient, or there is no connection at all?
Well, it is interesting. It's kind of like that with all like the wisdom of biology. Like you should be able to find out those through the sense and smell, the senses of taste and smell. You should be able to find those things that you're lacking and make sure you have a complete diet. Unfortunately, although that is not completely untrue, we are much more affected by the exposure and the environment and the availability of different nutrients. And so even in rodents has been shown that they will eat more of whatever they're giving more in the environment. So although we want to believe in this wisdom of we should eat whatever we are missing, there are some few things and instances where I can find robust evidence, like, for example, in pregnancy, there are issues that happen with diluting more of your volume and getting more water, and then they have this craving for salt and stuff.
Yeah.
Sometimes you need a little more salt. But the data show us that the most important thing in modulating what people end up eating is the amount of different nutrients and the environment where they are, whatever is more available, whatever is cheaper and easier to have access to.
So that's a good point, that basically your craving doesn't mean that you need it in biology and you miss something. It's more like craving, and you need to maybe control it. So people that crave chocolate, it doesn't mean that they need more chocolate. It's more like,
No, it's more that they've probably been eating chocolate and then they
yeah,
get that habit and then they are.
maybe it's a sort of even addiction. I know I love chocolate, and
I am a
I feel,
chocoholic too.
so I feel like I'm addicted to chocolate, but it doesn't mean that I need to eat a chocolate. And another interesting part of your work is focus on bariatric surgery and weight loss and flavor perception based on that, and definitely eating behavior and maybe alcohol drinking. So can you elaborate on that?
Sure. So maybe I will start by saying, what is bariatric surgery? I mean, most people, I assume they have heard about it, or they have a friend or a family member who maybe went through one of these procedures. So bariatric surgery is a weight loss surgery. And it is actually the most effective treatment that we know of today for severe obesity and its comorbidities. At least the one we have more long-time evidence that it works. People, after undergoing these surgeries, that will explain a little bit, they can lose 30% of their excess body weight, like 70% of their body weight when they get it, which is like 30% of their excess body weight. And the most important part is they're able to keep it for decades. Not everybody, unfortunately, but 70% of the patients undergoing these surgeries, they can keep their body, whatever they lose, for years, which is very unusual because in many other treatments, people can successfully lose weight, but then the problem is that they gain it back. So these surgeries change the gastrointestinal system in a way that it makes it more likely that they don't have hunger for the first couple of years, and then have a chance to learn a new diet and adhere to healthier diet patterns, and then they're able to keep that weight that they lost. So there are different bariatric procedures. The most common, they change as we learn through. So when I started my research, the most common was the gastric bypass and the lap band. In the gastric bypass, most of the stomach is bypassed, and there is a small pocket of the stomach connected to the jejunum. So the first part of the intestine is also bypassed. Whereas in the lap band, it was seen as a less invasive procedure because it's just like a silicone, like a rubber, that it was creating a constriction in the stomach, creating a small pocket, but the rest of the stomach and the intestine will remain the same. However, the problem with this is that lap band, people will lose less weight, and then they will more likely to recover it all back. So now this less than 2% of people are receiving lap band. And one new kid in the block that came like 10 years ago, it started being very popular, is the sleeve gastrectomy. Now that is the most important surgery done. Like 70% of the cases in the US and in the world are sleeve. And in this surgery, they cut 80% of the stomach, remove it from the body. And so the stomach and the intestine continue like if it was like a long sleeve, like a banana shape. And these surgeries, which interestingly, at the beginning, they were thinking they were just creating a small pocket in the stomach so you feel full and satiated sooner. And then they thought it was restrictive procedure. That's why you will lose weight. Some of them, they thought it was a little bit of malabsorption because it got so fast, the nutrients to the intestine. So but to this day, we know there is very little malabsorption. You absorb almost everything that you eat. The only thing that you don't absorb very well are some like some minerals like iron and others that you need to refill with pills. But it is not that why they work. So now we know it's mostly because of by changing the gastrointestinal system, there is a big change in the gut-brain connection. The peptides and all the messengers from the gut telling the brain when you're full and how much hunger you should have, all those things are changed. The microbiome is changed. There are changes in metabolism in a way that make you less hungry and reach satiety much, much sooner.
So it's like, in a way, you have Is it connected somehow to GLP-1 or we don't know?
Great question. So at the beginning, a lot of people got excited. So both gastric bypass and sleeve gastrectomy, although they changed the GI, the gastrointestinal system in different ways, they both significantly enhance the GLP-1 response.
Yeah.
And there is a lot of data supporting that, at least in part,
Yeah.
this is why it's such a successful procedure. Of course, there are some other data in animal models. They use a knockout animal GLP-1, and these surgeries still work.
Yeah.
So I don't want to say that's the only mechanism. I think there is a lot of redundancy in the system of why the surgery work. But I would also say that this enhanced GLP-1, which happens because when you have this surgery, when you consume some sugars or proteins that release GLP-1, the GLP-1 response is produced much earlier at a much higher and exaggerated response because your sugars are not absorbed slowly but very quickly, cause a peak in glucose, a peak in GLP-1, increased insulin. And so all these things make you feel satiated sooner.
Yeah.
So I think GLP-1 has a lot to do, but it's not the only mechanism.
And do we see an effect of the GLP-1 drug now on the amount of bariatric surgery, or we still see a lot of bariatric surgery?
This is, I will not, I really don't know the numbers of how much the introduction of the GLP-1 pharma had changed the numbers of the bariatric surgery. I know the bariatric surgeries are still being very frequently used. So what happened is also, I think at the same time during COVID, there was a lot of interruption with having these surgeries, which were more elective. So then some of the numbers have gone down since COVID. And then after COVID had recovered a little bit, not completely fully to that. There's like around 200,000 patients a year in the US. So there's still something going on. I don't know if not going or not growing that number or not going back is because of the introduction of GLP-1. I think that there is room for both that type of therapies. Another thing, these surgeries and the drugs have been also approved for children and teenagers in the last January by the American Academy of Pediatrics. So there is a lot of room for growing and using these therapies, maybe combine them too.
So you said that they got approval. From what age can you do bariatric surgery, inject the GLP-1? What is the youngest age that you can do it?
I'm not an expert on the.
But it's very young.
I know it can be. Of course, it's a case by case, and in medicine, everything is risk benefit. So I'm sure that they will try so many different things until you get to the point where a kid, a teenager will require. They will try to see many ways that they will lose weight by other means, and whatever is risk benefit is justify the surgery. They are approved.
Yeah.
Because
so let's go back with your permission to bariatric surgery and the effect on taste and perception. So what happened for a bariatric surgery patient?
So I was very curious about this question because I was very interested in understanding how obesity may be associated with changes in how you perceive sweetness, attraction, cravings for sweetness, and fats, and of course then the surgery make it even more interesting because people spontaneously after having these procedures they will go and say to the doctor, so did you operate in my gut or in my brain? Because I changed what I like to eat. Like now I don't like to eat much sweets. And doctors, they start collecting this data that they will kind of say what any nutritionist would love to hear from their patients. They will say, I don't eat as many candies and desserts. I eat more fruits and vegetables. And moreover, this is something that we know is not just patients trying to be adherent with their surgeons and the medical team. Because if you look at animal models, you take rodents, you make them had obesity, you do these surgeries, and they also change what they like to eat, and they don't want to go for much sugars or much fat. So there is something rooted in the biology of this surgery that is changing how they perceive and their preferences for food.
Yeah.
So one thing that first people start thinking is like, oh, maybe their taste gets enhanced and they are very sensitive now. They perceive sweetness at much lower concentrations, and so their palate is now tuned to different doses and they don't want to go for too high. So something we've been doing very meticulously in my lab has been looking at the sensitivity for all the different basic tastes. And we look at sugars and we look at glucose versus sucrose. This is the difference between these two different sugars. Looking at salt and citric acid for sour and all the different umami, like looking at all basic tastes. We never in my lab found using validated techniques, we never found a difference in how sensitive they were in the terms of what is the smaller concentration that they could detect or how strong they perceive those different tastes. But what we did found very early on, when you study them within the first year from their surgery, is that they change how much pleasure they derive from tasting something sweet. So at the very beginning, they will respond the same than before surgery, but after a few times they taste something sweet, they will go like, is this pleasurable? Like, I don't like it, no longer like it. And so it kind of like they feel this satiation of a sweet taste much sooner.
Yeah.
And so it's not that they dislike sweet altogether. It's just that they could have like, like one of those little mini cakes, and that's how much you can take. And so these surgeries were changing in a way, are helping people steers to a healthier diet because they much sooner reach satiation for these things that before surgery, they take them a long time until they will feel like I've hit the spot.
Yeah.
As a Longevity by Design podcast listener, you understand the value of improving your health for today and for all the years ahead. And if you want to live your healthiest, longest life possible, you need to understand what's going on inside. At Inside Tracker, we take a personalized approach to health span optimization that eliminates guesswork from your wellness plan. Inside Tracker analyzes blood biomarker and DNA data, along with physiomarker data from fitness trackers like Oura Ring, to deliver personalized food, supplement, lifestyle, and exercise recommendations that allow you to take control and improve your health span. And for a limited time, Longevity by Design listeners can get 20% off at the Inside Tracker store. So if you're ready to receive a personal health analysis and data-driven wellness plan to optimize your body for the long haul, then it's time to start inside. Visit insidetracker.com/podcast to get started today. That's insidetracker.com/podcast to get started today.
And do you see the same response with GLP-1 drugs?
Great question. I want to do the study. I haven't done it yet. It's, for some time I tried to do it, but it's complicated. Those drugs, the GLP-1 agonists, were actually out of the... you couldn't get your hands on those drugs. There were even patients were struggling to get them. They were so popular and so successful that... But eventually, we're going to get there. The hypothesis is that some of the things that you see with bariatric surgery in changing sweet preferences and things you'll see with the GLP-1 as well.
Yeah, but at least what we know about GLP-1, and again, I'm not an expert, is that when you are on the drug, you lose weight. When you are off the drug, you gain weight. What is interesting about bariatric surgery, as you said, 70 or 80%, they are, that's it. They are done. And so I assume that if it's the same, the perception change when you are off the drug. So something that the drug, like the secretion or not the injection of GLP-1, make you basically change, feel fuller from chocolate much faster, correct?
Yes, but I think, first of all, what happened with the surgery is that you get your endogenous GLP-1. You don't need to get it administered from the outside, right?
Yeah.
But an interesting point is that all these things we see with the sweetness, they don't like it as much, or they stop eating much sooner. They seem to take place on the first year, maybe in the second year, but we start seeing a rebound that after 2 years, even with the surgery, some people, or most people, they start again liking sweet as much as they did before. So I think that there is some adaptation and then some adaptation in which your set point changes.
Yeah.
And so my personal hypothesis, as shared by others in the field, is that you have those 2 years of kind of like a big help from the changing your gastrointestinal system and the structure of how your brain, your gut communicate to set up and do a new kind of like liking and change the preference and eat differently. If you only eat the same things you've been eating before surgery, just in smaller portions, after 2 years, those are the people more likely that will continue gaining all their weight. So you have a free in your brain to now a year where you don't feel hunger. People, they say, for the first time in my life, I don't feel I'm hungry. I eat because I need to eat the proteins, whatever that, right? So you had to use that time, capitalize on that time, and now train yourself to eat differently.
Yeah.
If you go back to the habits of eating a lot of sugars, a lot of fats, and then the biology will not help you any longer. After a couple of years, you may be at the same spot you were before surgery.
Yeah, so that's a very good lesson is you have the help of the GLP-1 or the bariatric surgery. So capitalize on that and change your behavior, not only the amount that anyway will eat less, but also the kind of food.
Yes, explore new
And
diets.
as you said at the beginning, talking about babies, so the first 2 years are the key. The same here. It's like you newborn with either GLP-1 or the bariatric surgery. Now you have the time. It will be much easier for you to train yourself to eat a better kind of food. And then if you'll do that, most likely you'll continue to do it for life. That's fair to say?
Yeah, I would think that's how I really interpret the data.
Yeah. Yeah. And what about another way to lose weight, which is basically lifestyle-induced weight loss? What is it similar to GLP-1 and bariatric surgery or not?
It is very difficult. It doesn't mean it cannot be doable. A lot of people can do it. They achieve they lose weight. They're able to keep it off. But the problem is that once a person gains, body weight, in particular, once you gain fat, there are a lot of things in the metabolism that make it very difficult to tame your hunger. And when you're trying to lose weight by diets that limit your calorie, it is difficult because you're hungry all the time.
Yeah.
And so it's very difficult to maintain.
Yeah.
So what these surgeries are doing and GLP-1 are doing is that they're giving you a break on feeling that level of how much can you stay when you're hungry, right? And you're in a bad mood. You are like have no energy. You cannot move. Then you move. You do a lot of exercise. You get more hungry. You want to eat more. So these surgeries somehow are tricking our biology, or our GLP-1 is tricking our biology to feel less hunger, feel satiated sooner. And an important thing both are doing is reducing our eating for emotions, our eating for the pleasure of eating. So you can eat because you need the calories, but homeostasis, but a lot of our eating is related to pleasure and the hedonic value of eating. So these surgeries and the GLP-1, what they're doing is they're cutting down your eating for pleasure a lot. So if you didn't eat a lot of that emotional eating and eating for pleasure, maybe GLP-1 agonists are not going to decrease your eating a lot if you have like a normal weight or a little bit overweight. Just make you feel more satiated. But in particular, it's very effective for people who are eating a lot because of all other reasons that we had to eat that are not related to our homeostatic hunger.
Okay. So between GLP-1 and bariatric surgery, what is the intervention that is you will recommend more for a person, or maybe it's depending on the...
Yeah, no, I am not. I think those are things that people need to discuss with their doctor and their medical team, and each person will be different. Like in medicine, everything is, I think we're going to go to personal medicine, right? And like the risk benefit for each person to understand which one. I think they're both really good tools that we have now for the first time, that we have a good a pharmacological treatment that works really for obesity, because the new agonists they're having really are hitting the amount of weight loss that you get with surgery, which was really the gold standard. So
okay, that's good to know, and I agree with you. I'm not a clinician either, so I won't recommend anything. But it's definitely a bariatric surgery that is around for a few decades is a good tool, and GLP-1 is an amazing drug, but each of them have a side effect or complications. So definitely,
ideally, we should prevent obesity. We should eat healthy since we are in the womb. But it's an ideal world.
But at least 50% of us are having overweight, and we know as a scientist that overweight is one of the highest risk factor, maybe other than your age, to have diseases and for mortality. So definitely, it's very important to maintain it, and nobody should feel shy to use bariatric surgery or GLP-1 in order to decrease it, because it's will increase your health and longevity.
Definitely. Plus, it's not just obesity. In fact, these are now called metabolic surgeries, even to move it away, as you said, from the stigma of weight, because these are the best treatment. This gastric bypass surgery is the best treatment we know of for a person who has severe obesity and diabetes. They remit from diabetes. At least they give up much of their medicines the first couple of years. They help with many other comorbidities of obesity. So definitely it's life-changing.
No, excellent. And that was a great discussion about bariatric surgery and the GLP-1 agonist. Another interesting part of your research is the non-nutritive sweeteners.
The alcohol we cannot forget, because I only talk about all the positive, and there is a dark side of metabolic surgery that I want to increase awareness. It's
Okay.
not to say people should not have these surgeries, but it's to have it very present and make sure that we have a medical team that is very present and screen for these things and help people early on not to ended up having an alcohol use problem after
Okay.
having these surgeries.
Okay, so can you elaborate on that? What are the alcohol issues with the surgery?
Yeah, so something that is interesting, because I think it got lost in literature. So how did the surgery show up as being a good, like an idea for treatment for obesity? So when people will have cancer in the stomach or gastric ulcers in their stomach, they will receive a surgery that will remove the stomach. And they noticed that these people start losing weight,
Yeah.
and that it was difficult for them to keep the weight on.
Yeah.
And so they said, oh, this side effect of this surgery, we can use it
Yeah.
for people with obesity.
Yeah.
Nevertheless, one thing that's also documented in the literature is that gastrectomies are associated with increased risk of an alcohol use disorder.
Mhm.
But that was kind of not translated.
Yeah.
And then when the numbers start, people start noticing that after decades of doing gastric bypass surgery, for example, in centers that were treating people with addiction and alcohol use disorder, they start noticing that there was an increased prevalence on people with this surgery showing up in these centers.
Yeah.
So there was much more rich population of number of people with this surgery who were in an alcohol use disorder than the number of people walking on the street with the surgery.
Yeah.
So they start finding an association. And then there are prospective and retrospective studies of big populations in Sweden. Every patient who underwent bariatric surgery, look at numbers, and they found that there is a twofold increase in the risk to develop an alcohol use disorder if you have gastric bypass compared to lap band, for example. And now the sleeve gastrectomy, although we know less because it's more recent, there is also starting to show that there are some data that is similar. Not all the data show the same, but that is similar, that people with sleeve gastrectomy are also at increased risk to develop an alcohol problem compared to people who have other surgeries.
And do we know why?
So we have different mechanisms and hypotheses why. And some of those are, I will present some that we study in the lab. Doesn't mean that those are the only mechanisms. But number one thing that we start thinking, and others, is that, of course, by changing the gastrointestinal system, it changes how the body handles alcohol.
Mm-hmm.
So when you drink alcohol, a fraction of what you drink, it never sees the brain because it's metabolized in your pass through the stomach and the liver. It's called the first pass metabolism of alcohol. So these surgeries, by changing, when I describe that they cut and bypass most of the stomach or even the first part of the intestine in gastric bypass, alcohol very rapidly hits the bloodstream.
Yeah.
And this first part that is metabolized in the stomach is gone.
Okay.
So when people drink after surgery, you may have a person with surgery will drink 1.5 standard drinks, and a standard drink is 1 can of beer or 1 shot of liquor or whatever is different doses, but 14 grams of alcohol. When you drink one, they will reach blood alcohol levels that are double what they would have before surgery or people compared to people without surgery. And not only they are double, the brain sees this immediately, like 5 to 9 minutes after you finish drinking, your brain is at that level. It's almost like you're having alcohol injected IV.
Yeah. Wow.
And we know that these things, the faster a psychotropic reaches the brain, the higher is the addiction potential. And so in the lab, we show that, at least in women, because now we're starting to study men, but 80% of the patients undergoing these treatments are women. And there are sex-related differences in how you handle alcohol.
Yeah.
So at least in women, we found both gastric bypass and sleeve gastrectomy, they both double how much alcohol they may see after they drink.
Wow.
And they speed it up. So they get drunk within 5 to 10 minutes after they finish drinking.
So they need to control their alcohol consumption more closely than...
Very closely. Not only that, so patients also report this, and I think this is what makes kind of like a system perfect for addiction. Patients report that they can get drunk and sober up 3 times in the same evening.
Mm-hmm.
So they drink a shot or they get really, really drunk, but very quickly that alcohol distributes through all the body and then they get sobered up.
So they can drink
and then
again.
They can drink again and get really, really drunk, but they don't have to go through all the hangover. Like if you want to, so they have a couple of drinks and they go above what a person would drink with 4 or 5. So they do binge drinking with social drinking. Just, so this is something very tricky because then the brain also develop more adaptations that you tolerate more the sedative effect of alcohol. And very soon you can keep on drinking and you don't feel much of the effects.
Wow, that's very good to know. And I assume that it's not the same for GLP-1 because you still have the stomach, so it will absorb.
It will be different. And in fact, GLP-1 drugs do the opposite because GLP-1 delay gastric emptying. And so it takes longer for alcohol. It will take longer for alcohol to be absorbed, and there were more chances for alcohol to be metabolized in the stomach before reaching the bloodstream. And interestingly, now that you mentioned, GLP-1 agonists are being studied. There are many studies going on that they could be helpful to tame alcohol intake. And so there is robust data in animal models that animals reduce how much alcohol they drink. There is anecdotal evidence from people saying when they're putting these drugs, I don't feel like drinking. I don't want to drink. I reduce my drinking. And there is now data starting to show some associations with the use of these medicines and decreasing how much alcohol they consume. So maybe they could also help with alcohol use disorder.
Oh, interesting. So what you're saying, a person that is suffer from alcoholism can inject a GLP-1 and maybe that can win him from that.
It may be the case. We still cannot, we cannot use it, we need to do clinical trials.
Yeah, no, of course.
Yes, but they are undergoing this, as we speak, are these trials.
Yeah.
And there is data supportive that it will help.
Yeah.
There is data coming up, you can see it in the conferences. There is data showing that what we see in animal models that is very clear that it helps them reduce how much alcohol they drink. In people, it seems that it may be the case.
Yeah. So that's very interesting. Another use of GLP-1.
The GLP-1.
Yeah.
It seems to be like the magical pill.
Yeah, exactly.
Diabetes first, obesity, and now maybe alcohol.
Yeah, I heard about
addictions.
kidney diseases and also cardiovascular. It's amazing.
Yes.
So another part of your research, which is also very interesting, is about basically sugar replacement or non-calorie sugar sweeteners. Is there any effect, or if there is, what is the effect of them on taste perception?
Yes, that is a fascinating area of research as well. I was very interested in understand. I was from all the different basic tastes when I was at Monell. I dedicated most of for sweets and bitter, but sweets were really interesting. And it was interesting when the data came out, like the first data. Now it seems recent to me, but it's been a long time, more than 10 years, 15 years, that they showed that the same taste receptors that we had in the tongue that were so proudly saying, oh, these are specific receptors we use for taste. The very same sweet taste receptor is expressed in many organs beyond the tongue. And particularly the sweet taste receptor expressed in the stomach, in the intestine, in the pancreas, and understanding what was the physiological role of that receptor. And of course, it makes sense that it was related with sensing glucose, with regulating when to trigger the insulin responses, absorbing glucose, and so on. And so then the basic question came very obvious. Oh, so those low-calorie sweeteners who activate the sweet taste receptor in the tongue, do they activate those receptors, and what is the aftermath effect?
Yeah, exactly.
And so I had to say that it is a difficult research to conduct because, first of all, there is a big family of non-caloric sweeteners. So you can, whatever you find with one, you cannot completely extrapolate to another. So in my lab, we have only looked at sucralose.
Yeah.
And with sucralose, my very basic question was, okay, sucralose, if it has no calories, but it has a sweet taste, can I change at all how your body regulates glucose? If I give you, if you only give them artificial sweetener, there is a lot of data that if they only consume artificial sweeteners, you cannot measure differences in their glucose. But what we did and other people have done is combine, because we typically combine carbs with the beverage. We don't have just drinking the sucrose. And so when we combine sucralose and a dose that it was kind of the one you found in a diet soda, and then we give them a big dose of glucose, like we use a clinical test, the glucose tolerance test, to see if we could move at all the curve of how your body responds when you give them to drink water or sucralose before drinking your glucose test. And what we found is that in people with obesity, when they consume sucralose, they change how they handle sugars. So glucose peak faster and higher, but then they go to a little bigger dip because it is also like a 20% increase on how much insulin is they have in their plasma. And all in all, it looked like they are more insulin resistant. On that particular event that we compare the same person, if you drink water or if you drink sucralose before having a glucose test.
Yeah.
And so that answers the question that despite having no calories, they may have some other metabolic effects. So
Yeah.
this has not been replicated by every lab, but we replicated in the lab. We did it again.
Yeah.
Interestingly, we did it with people with obesity again and people with normal weight. And we found that in people with obesity, we see the same. In people of normal weight, we didn't see the effect on their insulin response. So give us another, even more complex thing that the effect of the non-nutritive sweeteners may be different in different people. If you have diabetes, different. If you have insulin resistant, metabolic syndrome, if you have obesity or you have normal weight. To me, there is no doubt that these are chemicals that are stimulating a sweet taste receptor.
Yeah.
And it's a receptor in the body that has many other roles. So consuming it, depending on what you consume and how much is the dose, it has a lot of chances to do something.
Yeah.
Plus, in animal models, there is data showing that, and this is happening in rodents, it happens in piglets, it happens in cow, it happens in other models too, that you can increase feeding efficiency. So in animal models, if you spike their food with sucralose, they absorb the glucose of their diet much faster.
Yeah.
And in piglets, for example, they gain more weight, although they eat the same amount of calories. And so I think that we are not any of those animals, but if it's happening in all these species, there is a chance that consuming these sweeteners could affect, maybe not in everybody, depending on your own metabolism and personal vulnerabilities. But I think that it's data showing with epidemiological data is associated with the very same problems that you have when you have a heavy sugar diet.
Yeah.
So
basically, if I understood correctly, the receptor, we fool our receptor and think that we consume sugar, so our pancreas increase more insulin, and that can actually cause at the end insulin resistant and maybe diabetes faster. That's where you're going, or you're not sure?
I don't have all the data to make all the connections you said. It seems feasible.
Yeah.
And I don't know how much of this is mediated through the brain activating by the vagal nerve, the pancreas cephalic response, or how much it could also be locally, because some of these can get absorbed and activate receptors down the road. Another interesting concept that we know in the last few years is that before we only knew about the gut sending the hormone and this very slow system from the hormone community with the brain.
Yeah.
But now we know the neuropod, these are kind of like neurons expressed in those cells that are in the stomach. So in milliseconds, your brain gets almost like a synapses and knows if what is in your stomach is sucralose or glucose.
Yeah.
And both of these activate the sweet taste receptor, but they have different cascade of events, so they will cause different things. So these are chemicals that we need to think that, yes, they trick your brain, they trick your tongue in telling you, but they don't trick your gut. And so there are sensors there that can have different consequences of what you do. So maybe if you drink, one diet soda a week or something, you don't see much of an effect. But I think that drinking a gallon of this a week because you think it's just like having water, has no calories.
It's not water. That's what
it's not water. It has no calories. It still has physiologic consequences.
Exactly. You fool your brain, but you also fool your body, and then there are negative consequences for that. So that's a very good to know. But specifically, as you said, there are many 0 calories sweetener. Which of them, if you would need to recommend, which of them is the least, or you think that all of them are bad?
No, I think that there seem to be, sometimes we confuse safety with having effect. So they are safe. There is data that show they are not associated with cancer. They are not, there were some studies like saccharin and bladder cancer in rodents, and they show that it was actually very specific to an enzyme, and something happened in rodents. We don't have that. They removed the label. But so they are safe. There is data, or at least, they are safe. Maybe we learn more as we go through, and some of them are not so safe for everybody, like the sugar alcohols may be actually very harmful for people who are already at metabolic risk and for cardiovascular issues. There is a lot of new data that we need to learn, understand better, and analyze more. So maybe things we thought were safe, then we change the mind. But in any case, they seem to be generally safe, but they do seem to have an effect. And which one? I don't know. I will just think that if you're going to eat really like 1 spoon of sugar on your tea or coffee, I'll go for sugar.
So you will say that even with all the calories and all of that, go for the natural one and not don't go with the artificial sweetener. That's good to know. And another good point that you mentioned is about cancer. So because there is a lot of debate about that, as much as you know, there is no induction of cancer. So don't worry about cancer, but you still need to worry about the metabolic effect of
your metabolic health.
and those might we don't understand it fully, but your data show
They may have an effect.
Yeah, they might have an effect, and I was trying to connect the dot. It might even be an effect that increase the insulin sensitivity that at the end can cause diabetes. So be careful with that. Don't drink.
They may increase insulin resistance.
Yeah. So
Another thing is that I was trying to look is like, I said maybe if you, because these sweeteners activate the same sweet taste receptor than sugars, but they use different ligand points. They use different points in the receptor. So I said they're so effective in activating the receptor, tiny bits of because they're very effective. So I said maybe you use them a lot, you adapt the receptor so that maybe actually you even need to consume more sugars to see the sweetness.
Yeah.
So I was trying to study how these sweeteners may change how you perceive sweetness. So far in the lab, we haven't measured something that strongly will say, they perceive less sweetness if you use a lot of them. We think they perceive sweetness very much the same. But an interesting data is that when you study in the lab and you do a clinical trial, they give them the sweeteners or the sugars, and people are replacing sweeteners, sugars with the sweeteners.
Yeah.
Now, in typical life, when you study people, what consumers are doing, it seems that people who consume the low-calorie sweeteners are not using it to replace the sweetness of the sugars.
Yeah.
They're just having a sweeter diet.
Yeah.
If you look at how much sugar they consume with people who are non-consumers, they seem to consume the same amount of added sugars. It's just that in addition, they also have the sweeteners. So they're just having a very sweet diet. And I think that we need to train ourselves and learn to tame sweetness is a treat. It shouldn't be in everything, every day.
So don't let your baby drink Diet Coke.
Oh, no. It doesn't have calories, but you're only fueling an attraction to sweetness because it's also interesting that babies and children are more attracted. They like much higher levels of sweetness than adults.
Yeah.
And this is something that happens in biology. So even in rodents, you measure how much sweetness they like early on in life, and then you measure them when they reach adulthood. The levels of sweetness they like early on are much higher compared to adults.
Yeah.
And this is something also in biology, it's rooted in our biology. So kids are really attracted to sweetness. So help them not to be having sweetness all day long.
Yeah. No, that's a great insight. And I want to go back to the bitter taste. And I know that you mentioned that it's more like genetics. So, for example, I cannot stand the bitter taste, and I assume that it's not because I need more or less nutrient. It's more because of my genetics, as you said, depending on That's correct.
And interesting, we can link it with our previous topic because, some of these artificial sweeteners, they activate the bitter taste receptor, but depending on your genetics, some people feel bitterness when they taste them and some people don't.
Yeah.
So this same receptor for bitterness can be activated by some of these sweet non-caloric sweeteners. So some people really dislike the non-caloric sweetener because they feel it's bitter taste.
Interesting.
So bitter, some like it, some don't. We are born disliking bitter.
Yeah.
So if you take a baby, it doesn't matter which mammal, it can be a rat, it can be an orangutan, it can be a human, and you give them something bitter, they will gape and they will try to remove what is in their tongue. And this seems to be, we think that it came up because the plants evolved with the mammals, so plants didn't want to be eaten.
Yeah.
And mammals learned, and so they put poison, kind of like these are. So bitter is not just necessarily something negative, but it means biologically active.
Yeah.
So you don't want to take something that you don't know if it's going to be poisonous.
Yeah.
And so it is a very natural reflex to early on in ontogeny dislike bitter.
Yeah.
And then depending on your genetics, you'll be even more sensitive or less.
Yeah.
And as you grow up, you may learn to like it. You can learn to get the bitter and associate with the calories of whatever you're eating or maybe the effects. Alcohol tastes bitter. Beer, right?
Yeah, beer.
And so, but you learn to like it because you learn the flavor of beer with the effects of alcohol, right? And then you learn to like it.
So it's a negative with positive in a way.
Exactly. Yeah. So you can learn to like it, but depending on your genes, some people will be more likely to, in fact, it could be protective, some of your genetic, to start drinking alcohol earlier or smoking, not, smoking also nicotine tastes bitter. So if you have the some of the genetic variations that make you more likely to perceive bitterness, maybe you're more likely to be defended from drinking alcohol early on or smoking. Of course, then once you try it and you experiment with the effects, it changes the story, but we can learn to like it.
Yeah. Okay, very good. So COVID gave us an opportunity to basically see people that lose basically taste sense. What have you learned from that?
COVID was, well, in so many ways, such an interesting virus, and it still is.
Yeah,
So when COVID hits, the first news that people were saying, I cannot taste.
yeah,
All the people in the field of chemosensory were thinking, oh, people just cannot smell. So we tend to use we tend to use taste and flavor if they were a synonym.
yeah,
But actually, taste is very, very, very narrow sensory system. It tells you about the ligands interacting in your mouth, and it's just simple sweet, salty, bitter,
yeah,
sour, and umami or savory.
yeah,
Those are taste. Now, when you eat, a lot of the flavors of the food go through the retronasally, through the back of your mouth, and activate the nose, and
Yeah.
that's what we think flavor. So when we think chocolate, it's not a taste, it's a flavor of chocolate. Vanilla is a flavor. So when people have respiratory viruses or things, and your nose gets blocked, and then you don't smell, people go to the doctor and say, I lost my taste.
yeah,
But you lost your flavor because most of what we eat comes from the aromatics or food, right?
Yeah.
Taste is a very robust, difficult system to lose. And so with aging, we tend to lose audition, vision, smell. Taste, you lose a little bit, but it's the most remarkable conserved. And when you think on viruses, most viruses really affect smell.
Yeah.
So for us, at the very beginning, and then I was very fortunate to get in and interact. We were all at home in Zoom, so with the computers, I was part of the global consortium of chemosensory research. So we, investigators, we start getting together and make this group of people, and we meet every week on Zoom. And we start designing these surveys that we did in like 35 different languages, put it all over the world, and got a lot, like thousands of data, trying to understand how much is affected, COVID is affecting just smell, and people refer it as taste, or is it taste actually affected? And it was very early on, very clear that COVID was different than other respiratory virus, where other respiratory virus will only affect smell and people will just be confused with smell and taste. COVID actually did affect taste. Since people, we asked them to also taste sugar, taste salt, a little bit of a drop of lemon water, and they wouldn't taste anything.
Wow.
So COVID is very different from other respiratory viruses in which depleted us of all our sensory system, not only smell, which is more common to lose, taste, which I haven't heard. Very few in the history you've seen virus that affect taste. COVID did that. And even affect chemosensation, which is another chemical sense that is related with irritation, like the spiciness of chili peppers or like the coolness of menthol. So maybe you have seen videos of people eating like onions and mustard and toothpaste and saying, I don't taste anything. So COVID really affect all our senses. Interestingly, there were different windows of time on when these things were affected and recovered. So smell and taste were affected like almost like if you turn off the light. Like there's nothing. One day wake up and have nothing. Now, taste recover much sooner than smell. So taste will last only for a week or so, where smell will take at least a couple of weeks on most people who were fortunate enough to regain it. Unfortunately, some people, which is now part of what is considered long COVID, did not recover the sense of smell. And we're really trying to understand what can be done and how can we learn more of the sense to recover this, because it's affecting people in many ways other than nutrition. It's affecting, giving them depression. They feel isolated. They cannot connect with other people. So yes, COVID really put the chemical senses on the first row, because typically people other than me and the people working in my field, which is a narrow niche, we of course are fans of taste and smell, but most people in this planet don't care much about taste and smell until they lost it. They care about vision, audition, and we're very, unfortunately, we don't have much tools to help people when they lost their sense of taste or smell and what to do. So hopefully COVID put that light spot on okay, we need to do more science on this and help more. They are very important for health.
Absolutely, yeah. So that was a fascinating discussion, and we got to the end. And I always like to ask, what is your top tip for health span and longevity. So if you can come with some suggestion for our audience.
I think that I will come. It's boring because after so many years of studying and doing research and stuff, I think I may come up with the same tips that my grandmother would give me without no school.
Yeah.
Which I think is eating a healthy, balanced diet. I think that a little bit of everything we need because we need vitamins, macronutrients, and different things. So not to specialize on just focus on one thing. So having as much as possible a healthy, varied, balanced diet and move around and be, and have a social network, not to be isolated. I think those are the things we're learning that are helping people live long years and healthy with good quality of life. But yes, try to eat whatever has been, I think, move along out of things that are super processed. Try to eat foods that have nutrients, not just edible things that make you feel good for some time and make you sick for the long time. But that is my take home of more like than a scientist, of reading the literature and seeing what happened in different civilizations.
Yeah, sounds good. That's a very good recommendation. And I think we are coming up on our time. So thank you so much, Dr. Pepino. And we look forward to exploring the research in the field of longevity each month with you and the leading scientists. For more information, please go to www.instatracker.com/podcast. Thank you so much. It was a fascinating discussion.
Well, thank you. Thank you, Gil, for this opportunity.
Thanks for listening to Longevity by Design. Please subscribe to this podcast on Apple, Spotify, or YouTube. Longevity by Design is powered by Inside Tracker, a personalized health optimization platform that helps people improve their lives by improving their bodies from the inside out using personalized, science-backed recommendations for nutrition, supplements, and lifestyle changes. To learn more, visit insidetracker.com/podcast.